Hello everyone, welcome back to our channel. I'm Dr. Ashmita. In this video, let's continue with the morphology of Hobnail papillary thyroid cancer. In our previous video, we have discussed about the introduction and the etiopathogenesis. So let's continue from there. Let's study the histopathology beginning with the microscopic features. We'll continue in this under these headings, that is the architecture. Coming to the architecture of the Hobnail PTC, it gives a typical papillary or the micropapillary architecture. Papillary are this finger-like projections, and micropapillary clusters. They can form micropapillary clusters like this. So these are the papillary and micropapillary architecture, and there's no fibrovascular core. Usually papilla means a true papilla means it shall have this fibrovascular core. It consists of fibrous tissue along with admixed with blood vessels. Here, there's no fibrovascular core. The reason I have explained in the pathogenesis also and the introduction also, because there is down regulation of E-cadherin and upregulation of the EMT genes, that is epithelial mesenchymal transition genes. There's loss of structural support because the cells lose their polarity, cells lose their cohesion, they disperse, they become discohesive and disperse. When they disperse out from that original stock, obviously underneath it is no supporting structure. So these papillae, they do not have the tumor cells forming this papillary architecture or the micropapillary clusters. They do not have a supporting structure underneath them. So there's no fibrovascular core to them because of this E-cadherin loss and upregulation of epithelial mesenchymal transition genes which promote invasion and metastasis. So, and these papillae can be like arranged in back-to-back arrangement of the papillae. These will be like this. Papillae, one papillae, back to back, back to back, back to back. There's no gap in between this papillae. Either it can be back to back arrangement and otherwise all these papillae, they become fused and become one wide papilla. They become one wide papilla like this. These are the fused papillae. So this is the architecture given by the Hobnail PTC. Coming to the individual cell morphology, as we have said, it is hobnail cells. Hobnails means with an apical bulge. So this is the papillae. These are the tumor cells resting on the basement membrane. So they have a narrow stalk and a wide and apical bulge because of apical placement of this nucleus. So these are the hobnail cells. And this loss of cohesion. Cohesion means cohesion is brought about by E-cadherin. So this down regulation of E-cadherin, which is the glue that makes the cells stick to one another. So when this down regulation of E-cadherin, they will disperse from one another. They do not stick to one another. There's a gap between these cells, or they disperse out. They disperse out scattered as single cells or small clusters. So there's loss of cohesion. And there's high NC ratio, that is a pleomorphic nature. Nucleus is larger, nucleus like its bulky quantity is more than the cytoplasm. So pleomorphic nature. And classic PTC nuclear features are present, like nuclear clearing. It is clear. It can have grooves. So it is either clear, sorry, it is either clear or it can have this longitudinal groove giving it a coffee bean appearance or a pseudo inclusions. That is, a cytoplasmic pseudo inclusions can also be present within the nucleus. And the aggressive features like increase in mitosis. Because it is a rapidly growing tumor, cells will be in dividing phase. Cells in dividing phase are called mitotic figures. So this increase in mitotic activity means increased mitosis. So how many mitotic figures should be seen to call it an aggressive ones? So on a 10 high power field, at least 3 or more than 3 mitotic figures should be seen on 10 high power fields. So this mitotic or the rapid turnover is because of TP53 mutation, which is a tumor suppressor gene or the guardian of genome. When this is mutated, when this is overexpressed, that means there is a loss of cell control, loss of suppression, tumor suppression. It will divide rapidly. So there's mitotic figures, and third promoter means cell becomes immortal, it will survive. Mitotic figures appear as these dense dots or dense black dots, almost dark blue dots on the slide. These are the mitotic figures. And there are focal necrosis and apoptotic bodies. Focal necrosis, apoptotic bodies are like attributed for this high cell turnover. It is rapidly growing. The tumor is rapidly growing. The cells are rapidly dividing. When it is growing such fast, it is attributed because it is fast growing. Fast growth it will outspace the blood supply. It will outspace the blood supply. So the blood supply of the tumor is not sufficient to meet the demands of so fast growing tumor cells. The tumor cannot receive that required oxygen nutrients, hence they undergo necrosis or apoptosis. The cell death is attributed because it fast growth is more than the blood supply. That's the reason. Coming to the next feature, there is fibrosis and stromal reaction. So as we have said, it is aggressive, fast-growing tumor. It grows fast. There is loss of cell polarity, loss of cohesion. That means individual cells will invade into the surrounding stroma. So the stroma will not keep quiet. The host shall mount a response against the tumor. So it will mount response by this deposition of fibrocollagenous tissue, that is fibrosis. The stroma becomes more densely fibrous. That is also called, this reaction is called desmoplasia. Desmoplasia is the stromal reaction towards the fast growing tumor. It is a stromal reaction to fast growing tumor cells. Fast growing tumor cells. And there can be capsular vascular invasion. So there is loss of E-cadherin. There is loss of E-cadherin and epithelial mesenchymal transition genes are activated. So this will cause loss of E-cadherin means the cell will disperse. Epithelial mesenchymal transition means it will migrate. So all this will help in migration of the tumor cells. Migration means it will help in invasion, that is invade the local stroma, surrounding stroma, and can also like invade the capsule and reach the blood vessels. So that is called metastasis. They help in invasion and metastasis to distant sites also. So distant sites means extrathyroidal extension is also possible. Most commonly regional cervical lymph nodes or the trachea, larynx, the neck strap muscles, the surrounding fat or soft tissues, all these are involved. So the diagnostic point here is to call it a Hobnail PTC, at least 30%, 30% or more than 30% of the tumor cells that you see on the slide it must show this Hobnail morphology with apical bulging. If it is less than 30%, then it is said to be a papillary thyroid cancer because it has all the features of classical PTC nuclear features. So we call it a PTC with focal Hobnail morphology. Less than 30% of the cells are showing you this Hobnail morphology. Then you can say it as a focal. Some foci are showing this Hobnail morphology. So it is reported as a classical papillary thyroid cancer with focal Hobnail morphology. So these are the histopathology images. Here, what we see clearly from the slide is there is a papillae. Here there are cells with apical snouting. So the nucleus is apically located. This is the nucleus apically located. The cells are bulging out into the lumen. These cells are bulging out into the lumen. So typical hobnail cells are visualized. These are the hobnail cells. And also there's loss of cohesion. We see this individual cell, they are scattered. Scattered individual cells are seen. These are the hobnail cells. These are the hobnail. These are the hobnail cells. These are the scattered individual cells because of loss of cohesion. And also you can see this clearing of this nuclear side, nuclear clearing is also seen. And this also shows you the clear hobnailing, clear apical bulging. Nucleus is apically located. Here, single individual cell because of loss of cohesion. So these are the hobnail cells. So this Papillary architecture is also seen here. This is the papillary architecture from where these hobnail cells are arising. Hobnail cells. Here in this slide, in this histopathology slide, these are the papillae. These are the papillae. Here hobnails are seen lining this papillae. That is the apical bulging. These are the apical bulging. Here the individual cells. These are individual cells scattered because of loss of cohesion. These are the hobnail cells coming out from the papillae, bulging out into the lumen. These are again the individual cells. And to the center of this zone, this area, here it shows necrosis, like there are no particular cell outline. Entirely it is pinkish material. This is a necrotic area. This is a necrotic area suggestive of aggressiveness of the tumor. Here again the slide again shows you typical papillae with hobnail cells. These are again the hobnail cells with apical bulging. Nucleus located apically. This loss of polarity. Nucleus located apically means loss of polarity. These are the hobnail cells. These are the hobnail cells. So individual scattered cells are also seen. And in all this papillae, you never visualize any fibrovascular core here. There is no fibrovascular core in any of this papillae. See, there is no center stalk. Fibrovascular core is absent. So here, these are the micropapillary clusters. These are the micropapillary clusters. Here, the larger papillae showing the fibrovascular core, but the typical micropapillae, they do not show the fibrovascular core. The cells, they have this apical snouting with nucleus located apically. Here also, you can see there's one papilla. Cells, they with an apical bulge. These are apical bulge. They have apical snouting, that is cytoplasm, and the nucleus bulging from the apex. These are the hobnail cells. So this is the IHC immunohistochemical staining image of P53. Since P53 is mutated, it is overly expressed. Therefore, this brown stain is seen. So let's differentiate the gross features of classical PTC with the hobnail PTC. Grossly, the classical PTC, classical means it's a slow growing PTC, so the size will be less than 2 centimeters. Coming to the hobnail PTC, it is fast growing, so the size will be bigger than 2 centimeters. Because of fast growth is larger, it is more than 2 centimeters. Coming to the margins, it is slow growing, low risk. That means it is well circumscribed. The classical ones is well circumscribed. That means here this is a tumor, so this tumor will be well circumscribed here, like this. Hobnail is aggressive. So aggressive means here this is the tissue. The tumor will be like infiltrating, like it is as if growing into all the surrounding tissue. It is trying to infiltrate it, trying to invade into the surrounding structures. That is infiltrative margins. And consistency of the classical PTC is soft to firm. But whereas in hobnail PTC it is firm to hard, which is attributed to the desmoplastic reaction that we have said. The tumor cells grow at a faster rate and they invade the surrounding stroma. The stroma will respond to the tumor cells by depositing more fibrocollagenous tissue. This increase in fibrosis is called the desmoplasia, the desmoplastic reactions, because of the cytokines released by the tumor cells. Coming to the necrosis and hemorrhage, classical PTC, it is rare. Whereas in hobnail PTC, necrosis and hemorrhage is common because the tumor cells grow at such a fast pace that they will outspace the blood supply. Because of lack of blood supply, lack of oxygen nutrition, the tumor cells undergo necrosis. So necrosis is very common. Hemorrhages are because of vascular invasion. And coming to the extrathyroidal extension, classical PTC occasionally show the extrathyroidal extensions, whereas the hobnail PTC being aggressive, it will extend to the capsule, to the vascular structures, to the surrounding extrathyroidal tissues like the cervical lymph nodes, the strap muscles, the trachea, larynx. So all these are involved. Strap muscles, trachea, soft tissue, lymphovascular invasion, cervical lymph nodes, all these are metastasized by this hobnail PTC. Coming to the clinical and prognostic comparisons between the hobnail PTC and the classical PTC, the age predilection is Hobnail PTCs, or we'll start with the classical PTC, comparing first with the classical PTC. So the age prediction for this classical PTC, they are seen in young females between 30 to 40 years, whereas Hobnail's one, they are seen in elderly females ranging from 55 to 60 years of age. And clinical presentation is the classical ones are slow growing, they are slow and they are painless. So, because they're slow and they are painless, they are only an incidental finding. Classical PTC is incidental finding. Whereas Hobnail PTC is aggressive. It has an aggressive course, so it is rapidly enlarging. So, the patient presents with a thyroidal mass, sometimes extrathyroidal extension will result in when the cervical lymph nodes are involved, it will result in cervical lymph node enlargement. So, cervical lymphadenopathy is also a common presentation in these patients. Coming to the lymph node metastasis, the classical PTC, they show that 30 to 50% of the cases they will show lymph node metastasis, whereas the Hobnail ones, aggressive ones, they more commonly show the lymph node mets about 80% of the cases. Distant mets are also rare with the classical ones, whereas the aggressive ones, the distant mets are more common, like lungs, bone, brain are the most common sites to be involved by the Hobnail PTC. Coming to the recurrence rate, the classical ones have a low recurrence rate. It is low growing, so it is low risk, so it has a low recurrence rate, about 10% may recur. Whereas the aggressive ones will have this higher recurrence rate of about 50%. And prognosis also, the classical ones will have an excellent prognosis with a 10-year survival rate be more than 95%, whereas the Hobnail variant will have a poor prognosis and the 5-year survival rate is only 80%. So this is the comparison between the classical PTC and the Hobnail PTC in terms of this clinical behavior and the prognostic comparisons. And coming to investigations, so the thyroid function test in this Hobnail PTC, it mostly shows this euthyroid state. Though the normal tissue is replaced by this neoplastic thyroid tissue, it does not interfere with thyroid hormone synthesis or release. So thyroid function test, usually the hormone status remains normal. Coming to the ultrasound of the neck, they show an hypoechoic lesion. The lesion is hypoechoic with irregular margins because it's infiltrative, irregular margins, and microcalcifications are commonly seen, and there can be extrathyroidal extension. If there are extrathyroidal extensions like cervical lymph nodes, if commonly involved, suspicious nodes can also be seen. And on FNAC, the cells with hobnail morphology is seen. On FNAC slide, cells are seen which show this hobnail morphology, and micropapillary clusters are seen, that is small clusters. Nuclear grooving is seen. Nucleus will show again the same grooves, and pseudo-inclusions, cytoplasmic pseudo-inclusions are seen. Coming to this histopathological examination, more than we are studying the microscopy. So to diagnose as Hobnail PTC, 30% or more than 30% of the cells should show this Hobnail morphology. Mitotic figures of 3 or more than 3 per 10 hypo of field, tumor necrosis, capsular and vascular invasions are more commonly encountered on the biopsy slide. Coming to the IHC, this TTF1. So, TTF thyroid transcription factor 1, thyroglobulin, PAX8, Ki67 is high, and P53 is overly expressed because of mutation. Nuclear beta catenin is positive, and there is loss of membrane E cadherin. So, all these are positive. These markers are positive. Only E cadherin is lost in this Hobnail PTC. Coming to the molecular studies, the mutations are BRAF V600E is the most common mutation. So the all the cancer first of all starts with the BRAF V600E, most common mutation. It will lead to differentiated cancer. Later the additional mutations like TERT promoter, TP53 mutations, PIK3CA, these are also seen. The serum thyroglobulin levels are elevated preoperatively. So it is used as a monitoring tool post-operatively. So this, if at all the thyroglobulin levels are still raised, they will indicate recurrence or metastasis. And a CT MRI scan, they are done to know this extrathyroidal extension. PET CT scan also increased FDG uptake will indicate metabolically active. It will indicate metabolically active metastasis. CT MRI are done for this extrathyroidal extension. And radioiodine uptake scan will be poor. It will show poor uptake or the absent uptake. The treatment for this is we do a total thyroidectomy. It is an aggressive tumor, so entire thyroid gland will be removed. And if at all cervical lymph nodes are involved, lymph node dissection is done in cases of Hobnail PTC. So this is all about the morphology, the clinical comparisons, prognosis, the investigations. So this is all about the class Hobnail PTC. And here in this gross images, I have forgot to show you the gross image. It will show a multilobulated appearance or polylobulated appearance. It is usually larger. This is of approximately 12 centimeters in size. On cut section, so you see a good capsule. Here, these white dots are the microcalcifications. Few cystic spaces. These are the cystic spaces seen. So these white dots are the microcalcifications. These are the cystic spaces. These are the cystic spaces. Here papillae are seen. Papillary fronds can be seen. Here, these are the papillary fronds like this. So this is about all about the Hobnail PTC. So if you find this video useful, please like, share and subscribe to our channel. Thank you.